Hi everyone, I'm Lahiru and this is Casey Park with me, and today we're going to do a really special episode because this is the first time I think we're doing a double podcast for ABC Anaesthesia and Broom Doc. So welcome, Casey.
Thanks for inviting me, Lahiru.
So pretty much what we want to talk about was very specific to the outside of the metropolitan context, which is when you get obstetric patients, and how do you decide whether they're going to be okay to be done in a rural or remote context? And, you know, I'm here in Broome with Casey. He comes up here regularly as a visiting GP Anaesthetist, but you're an emergency physician?
Not really, but I work in a big hospital, yep.
Sounds good. And you're a GP?
GP.
And from what I know, you do a bit of everything. You've got your ultrasound formal qualification.
Yep. And
you run Broom Doc's podcast. And I think you just contribute to all the education around Australia, really.
I like turning up on other people's podcasts. It's my hobby.
Fantastic. Cross-pollination. So I thought we'd just kind of launch straight into it. The specific kind of objective that we want to talk about is the indications for referral of pregnant patients, obstetric patients, to more specialized centers for obstetric anesthesia. And, you know, I work in a tertiary obstetric hospital. I'm very fortunate that we rarely refer anyone out because we have a lot of facilities and a lot of expertise and whatever else, and, you know, just a lot of systems in place. But what is it like working in places you work?
Yeah, so this is a really great example of where the GP Anaesthetist really is at the centre of a lot of this decision-making, because there's so many factors to consider when you think about obstetric anaesthetics. There's the woman and what's going on with her. There's the baby and what's going on with the baby. There might be obstetric issues, and there can also be issues of distance. And then there's a lot of social stuff that comes into it as well. So, you know, a woman with 6 kids is very unlikely to want to go to the city for an operation. And obviously distance is also really important. So if you're just next door to a big hospital, that changes the calculation compared to, say, way up here in Broome, where we're, you know, a couple of days drive from the next place. So there's a lot that goes in. Yeah.
So and I like that. This is patient-centered care, but it sounds like you're going to have a lot of tension between, let's say a patient comes in and they've got so many reasons to just want to be in Broome or another rural centre, and you think that they really, based on all the other factors, probably should go to an external centre for whatever reason. And then there's tension that the patient would really want to stay, and you're faced with that conundrum. Like, how do you?
Yes, it's a really tricky one. And the conversation in my head goes, obviously, there are some things that are complete deal breakers. So there's some things like mathematically, for example, in Broome, we're only allowed to do women up to a certain BMI. And once they're above that BMI, then it's sort of automatic referral. And in some way, those are the easy ones, usually because you can't change math. Although we do have women that get a little bit taller occasionally. And so there's some things that are just like local policy, but I'd say for 90% of our patients, it comes down to that shared decision making, because we know that, you know, for example, things like BMI, the risk starts to creep up as your numbers get higher, but it's not like a cut and, you know, there's not like a magic line in the sand where it's definitely high risk or definitely low risk. And you have to sort of go through all that, your thorough anaesthetic assessment, and sort of have a chat to the patient and see how risk averse they are. And obviously amongst GP anaesthetists out there in the bush, there's different levels of experience, and what I might be comfortable with may be different to what you or one of my colleagues would be. So it's really tricky. And so you sort of need to have a good understanding of that risk and what it actually means in terms of your hospital and for the patient's experience.
Yeah, so that's interesting about the cutoff. So I work in a small private hospital that does have a BMI limit that's suggested, but once a patient reaches that limit, then it's up to the anaesthetic and surgical discretion. And often, because I'm just doing very, very low risk operations, we often just say, as long as they have just minimal sedation, they can have this procedure. And, you know, we know that's pretty safe. But is this a hard limit that hospitals have here or in other contexts?
It is a hard limit within our health system here, which is good because, you know, we all like to have a rational reason for making these decisions. Unfortunately, it doesn't always work that way, particularly in really remote practice like up here in Broome, in that often women might turn up at 39 weeks and that's the first time you've seen them, and it's really too late to make that decision at that point. So the way we tend to get around that is we tend to have a really team-centered approach in that I would never make that decision on my own. I'd get 2 or possibly even 3 of my colleagues to sort of sit down and think about this case with me. And you know, I've been doing this a long time, and my level of comfort may be different to one of my more junior colleagues. And so you sort of have to plan for, I guess, be a bit of a pessimist and plan for the worst case scenario, but within the limits of what is actually possible, because if a patient refuses to go, it can be really, really tricky. So
interesting. Okay, so that's a good tip. It's definitely a shared decision-making model.
Yep.
Or what one of my registrars told me as an intern, share the blame.
Share the blame, yeah.
That's a really useful.
Well, I know who the most conservative of my colleagues is, so I usually just phone them. And if they're happy to do the case, then that's great. So it's about knowing your team. And that's one of the beauties of working in a small hospital, is that you sort of know your mates well. Yep.
Yeah, okay.
Yep.
So that's interesting. So let's say that's actually a good thing to address. In my mind, I've got this framework that I'll always be thinking about not just the patient and their pathology, but also, the place I'm at, the personnel and the team I have, and maybe the staff, the post-op monitoring and all that kind of stuff, as well as, so those are probably the main factors. But all of this is in an elective context. So like you said, if it's emergency and someone comes at 39 weeks right there in labor with some kind of issue, then you have to crack on. So this is purely discussing maybe the indications of referral for a elective context. So, let's talk more about that. So patient comes in with, a patient has their unique circumstance and their pathology. What other kind of factors then? Yeah,
so I guess I think a healthy dose of anaesthetic pessimism, in that you look at the patient and usually, say, a pregnant woman who's planning to deliver, or maybe she's due to have an elective cesarean section, you sort of imagine what are all the things that could go wrong, and in the worst case scenario, what would be happening. So, it's usually a general anaesthetic with a big bleed, would be the things that would sort of make me think this is something I need to plan for in my head. And so if this woman's had previous airway difficulties, or she looks really difficult, or has an untested airway, and there's a lot of unknowns, then that would be something that would make me push that patient more towards, let's refer to tertiary for those reasons. Whereas if obviously there's a lot of obstetric factors, so if the placenta's a bit low and the obstetrician's telling you that they're a bit worried, then, or there's, they're querying, placenta accreta or something like that, then those sorts of things that are out of our hands. And I try to push that back to the obstetrics team and see how comfortable they are. But generally, those are things that would push me more towards going that way. So I sort of plan in my head for what would be the worst case scenario on the day, and how would I feel if that were to happen. And usually, for the vast majority of women, they don't really have any, young healthy women, they don't really have any reasons to refer them, so we're happy. But I sort of do that sort of anaesthetic pessimism sort of fantasy in my head and think, what could possibly go wrong? Am I happy with all of the above? So
right. And I guess, so let's say for a junior anaesthetist in training or GP anaesthetist who are going out into this rural environment, usually there's going to be senior people there that will know the lay of the land. But the way you think about it is what's most likely to go wrong. So bleeds. And so do we have the systems? Do we have a massive transfusion protocol, a blood bank, maybe a hematologist on call? Do you have the level 1? Do you have all those facilities to replace blood rapidly? And then that's common. And then if they've got any other specific things, so airway problems, any weird and wonderful diseases, bleeding deaths.
And often they're things like, platelet issues and things like that. So these are things that we usually know well in advance, so we can sort of plan for that. So those are things that we can get ahead of. But I guess it's that real team-based approach as well, because we never operate on our own with these situations, and you've always got someone nearby. I think probably the other thing that we mentioned, because this is obstetrics, obviously, is like plan A is always titular spinal for other elective or emergency deliveries usually. And I guess that's the one thing that is a bit different to the rest of anaesthetics, and that is usually spinal's not plan A. And you often look at women and you think this could be easier, it could be hard. And I guess that's where it really comes down to your level of comfort. So I know a lot of junior GP anaesthetists, they might have done 40, 50, 100 cesareans, but you don't know how good you are until you've missed one. And that's usually the rate limiting step. Is we've all had that experience where we haven't been able to get a spinal in, and it's very humbling. And so certainly over my career, I've had that happen a few times where I've sort of gone back to my own sort of level of skill and thought, what's my plan B? Because you need to have a plan B for all these situations.
Let's backtrack to actually one thing you mentioned, which was the low-lying placenta and the adhesive placental disorders, placenta accreta. Could you tell us, what is the issue with low-lying placenta, and then these adhesive disorders? What happens with those?
Yeah, so I'm not an obstetrician, but I'm just a paranoid anaesthetist. But
As am I.
So essentially, with the low-lying placentas, particularly my understanding from the obstetric world is if they're more anterior and there's going to be a cesarean or potentially a cesarean happening, and the obstetricians are going to have to make their incision through that, then that's the big issue where there's going to be a lot of bleeding. And particularly in women that have had previous cesareans and have a scar where the placenta may be adherent or possibly invading into that scar, then we know that those are really high risk for bleeding. And to be honest, like if once we've got that on cards, we really shouldn't be doing those, I think, in most rural areas, because I think we just don't have the resources in the blood bank to deal with it. And I know that in tertiary hospitals, they usually are running things like Rotem and all sorts of things, which we're definitely not doing in the country. So, so in some ways, those aren't too scary because you usually know about them in advance with all the ultrasound that happens nowadays. Yeah,
exactly. Yeah, and I remember looking at the stats on this. So if you had one previous Caesar, there's some rate of up to 10% of having a credit if you have a low-lying placenta over that. Once you get to like 3 or 4 or 5 previous Caesars and a low-lying placenta, it's almost like flipping a coin whether you're going to have an adhesive placenta, which is horrible when the surgeons, if you've ever seen them trying to take this accretor out, it's just attached to it. It just doesn't come out, and the uterus doesn't contract. It's always already poor contracting in the lower segment, and now it's just not doing anything, and it's just it's just horrible.
It is something that it's probably my worst case scenario for up here in Broome is if you're pushed into a corner where you have to operate on someone like that. And most rural hospitals don't have the blood bank facilities. Like we can all put in big lines, but if you don't actually have the facilities, and you don't have all those fancy sort of things that can stop bleeding, and you don't have the surgical capabilities often to do that, because often we're working with GP obstetricians as well. So they may not be really comfortable with putting in a lot of these devices that can save the day.
It's almost like the question: if you have any kind of thought of this is going to go badly with bleed, having that very early conversation, whether it's before the case of doing, what are your next steps, whether you are using the Bacri balloon or doing a V-length suture, or can you do a hysterectomy? Because, hey, this is our only option now.
Yeah, absolutely. And I think the 3 longest nights of my career have involved this exact scenario. So it never happens in the daytime. It always happens at 3 a.m. and there's no one else around here.
What is that?
I don't know.
Okay, so we've got this. That's interesting. So you've got your bleed risk stuff, and everything that goes along with that, which is patient specific, and then actually finding out what your hospital has. Often asking the experienced anaesthetist or GP anaesthetist already there really is your go-to for whether you can do a case or not. Particular patient issues like BMI. Any other, like in your experience, do you get some late presentations of just random diseases like neurological musculoskeletal?
So I guess it's maybe a little bit more specific to Broome, but we do tend to see a lot of young women that have sometimes quite advanced rheumatic heart disease who rock in, usually at 30-something weeks, having not had a lot of antenatal care, and sometimes with quite good going mitral disease, for example, or severe aortic disease. And that's really tricky from an anaesthetic point of view, because we all know that, people with really bad heart disease plus pregnancy, and then you give them a GA or a spinal or whatever it is, it can very quickly go pear-shaped. So that's something that we sort of think about a lot up here in Broome, and I guess that's more of a maternal factor that we see a bit of. So it's nice to have some echocardiography and know exactly what's going on with all of that, which is probably something that maybe we don't think about too much in sort of down south, but it's certainly a big problem up here.
And would you say there's any absolute cutoffs? Like I'm thinking in my head, if someone's got heart failure of any sort, or any stenotic valve lesions, it'd probably be a no.
I think if they do have severe disease, then it's easy. But often we have those unknowns, and I think you can get an echo, but echoes can also be not quite entirely accurate. So I think if you know that there's at least moderate valve disease, particularly the stenotic ones, then it's easier just to refer those patients on, because that's more about the post-op stuff, because you can still put them off to sleep and tube them and do all that, but it may go particularly badly after that. So I think having an ICU as backup and having cardiothoracics or an interventional cardiologist that can help you out, that doesn't exist outside of the metro. So I think that's useful.
How about the other lesion? Like let's say any kind of aortic stenosis, mitral stenosis, HOCM, pretty much we're going to refer these. Absolutely. If it's moderate or any kind of severity. But how about regurgitant lesions? Do you reckon those would be okay? getting specific. But
yeah, it's getting very specific. I think if you know about them in advance and you think that that's something like, obviously we see a lot of mild disease because we have a lot of up here. So if you've got someone with mild disease and you've done your proper anaesthetic assessment and they seem to have good physiological reserve and they don't have any symptoms, that's probably one where I would say that's reasonable. But as soon as you start getting into that moderate range, I think it's just easier to send them out because
why would you roll the dice?
I don't think you're gaining anything by keeping them here in the rural areas. And to be honest, like once they've had the baby, then they're in the right place to get the appropriate interventions if they need to, because sometimes they do need something done. But yeah, I think it's reasonable to do. I think we put there's a lot of pride in country about, let's keep these people in country. But I've seen that go wrong as well. And I think, and spending a week in the city is not the end of the world. And so you sort of need to be realistic about what you can and can't do. So I don't roll the dice especially if there's unknowns. Yeah,
that's interesting. I get the sense that it's not like the Wild West. It really is. You go to these rural centres and the decision making is conservative and rightfully so.
Yeah.
And it would be extenuating circumstances for whatever other reason that you maybe are forced to crack on with.
Yeah, and I guess in some ways there's emergency scenarios where a woman just rocks in and she's got bad heart failure but she's already in labour or having a bleed. In some ways you don't have a choice, and that's sort of how we get our experience, unfortunately, as we learn from that. But if you've got the elective option, then I think it's just easy to push those people to a big centre. Yeah,
good to know.
Yep.
So it's pretty much, that really is kind of the patient and pathology stuff I think covered.
Yep.
If we move on to, and we touched on place, because then it really is the systems of, do you have when you're in a particular hospital, like fiber optic gear and bank and things.
Yep.
In the obstetric context, what other things have come up in your career about the place that you work at and suitability?
So I guess in terms of place, if you look at Australia as a whole, there's a big range of place. So obviously Broome, we're a medium-sized hospital. We've got some really good experienced GP anaesthetists, and so we might take on more, and we're a long way from the city. So we might take on a bit more than, say, they do in Derby or somewhere that's a bit closer to the city where referral is much easier. So you sort of need to understand your team and the resources within the hospital. And so I think knowing that when you go out into the country is really important to sort of think about what place is. I guess the other thing is that sometimes transfer is an easy option in that you can just put the patient on a plane, but sometimes transfer is not a really easy option, especially if the woman's already in labour. And so we've certainly had that experience over the years where we've had to make that call where, what's the better thing to do? Do we put this woman who may deliver a very premature baby on a plane and hope that they get to the big centre, or do we keep them here where they're, hopefully, if they're going to give birth, we've got all the resources around it and it's not in a plane in the middle of the night. Yeah. So that has come up a few times over my career where we've had to sort of make that decision as to where the best place is to deliver that patient.
And this is their kind of almost an active labour.
Or they're in labour, or they're having a bleed or something that means that the obstetricians just want to crack on and get the baby out. So so that can be a really tricky one, and certainly that is something that you really want to sit down with the whole team, obstetrics, paediatricians, and think about the whole thing and your retrievalists as well, about what the right thing to do is, because I've had women over the years that we've put them on tocolytics and they've stopped at like 9.7 centimeters, and you're like, oh, what do we do now? So it's really tricky. You know what I mean? Like they just stopped, and you think, right, well, the plan was to get them out, and now we can't really fly them in this state. So there's some really tricky scenarios that do come up in obstetrics.
Because I guess that place thing then really, again, you are thinking of the blood bank and the neonatal services and whether they have the space for that in this hospital.
Yep.
But you mentioned like the fact that if you're in Broome, you're a moderate sized hospital, really far away, that almost always becomes a problem. Yeah. Or a factor in why you keep them there.
Yeah. It's really tricky. And I think WA is a little bit different to a lot of Australia in that we tend to have these really big distances. So it's sometimes it's very difficult to make that call. A lot of places like, rural New South Wales and Queensland, sometimes it's an hour's flight or, a short drive to the bigger centre. Yeah. And so you may have a completely different matrix in your head about how you make those decisions in those places. But it's something that you really want to ponder on and think about with your team, sort of, at a CME meeting, and just go through some of these scenarios and say, what would we do if this were to happen? Because it can be quite lonely when these things come up.
We're just checking on the WhatsApp group.
That's right.
The meeting isn't happening in the WhatsApp group.
As you said, share the blame.
I mean, as we're going through this, obviously, we're touching on lots of different areas, but I mean, are there rigid or very protocolized rules about this transfer and referral?
No, not particularly. It very much comes down to a case-by-case basis, and like a lot of patient factors and a lot of obstetric factors come into it. So it really is something that you need to be actively talking to your colleagues about all the time. So I'd say most of these are, apart from some very general cutoffs like the BMI thing and that where it's maths, most of this is just case-by-case basis. So
Are there ASA cutoffs?
Are they?
ASA cutoffs?
Yeah, so we tend not to do, so we do ASA 1 and 2. We don't do ASA 3, depending on what their ASA 3 is.
Pregnant lady of childbearing age, the ASA 3, that's
pretty rare. And those are our heart disease patients usually, or people with kidney problems up here. There's something wrong. And then obviously there's gestational age, so we obviously don't do premature babies. And over the last couple of years, we've crept back to doing smaller and earlier babies. But we had more paediatricians in a nursery now. And so that's something you really got to know as well.
So that's probably good to touch on then. So in terms of, we're talking about place and pathology and patient and personnel. So the obstetrician, their services, especially in neonatal services. How low would you go down here?
Yeah, so 35 weeks is what our thing is at the moment, although we certainly often pushed into the corner where we're doing smaller patients, and often we're the ones that end up managing the airway as well. So it can be quite tricky. We try and avoid doing less than 35 weeks, but it's a common problem, unfortunately, in the north part of Australia that we have this prematurity. So we do try and avoid anything under that. But particularly if you've got a really growth restricted baby, or got severe maternal diabetes or whatever, and you just know that they're going to run into trouble, it's not a deal breaker, but it's something that would push us more towards tertiary if we're thinking, well, if the anaesthetic I'm a bit iffy about, and I know that this baby's going to come out and need to go to a tertiary NICU, there's just no point in keeping them in a small hospital, I don't think. So sometimes it can be a nice excuse for us if we've got a baby that needs help. We can say, right, you can all go. So that can be useful. Yeah.
Yeah, nice. Yeah. And it sounds like 35 weeks. And that would be Broome, but definitely not another centre. So crossing or
So I think Broome's 35. I think the others are 37, or basically term. And if they're too much earlier, and that comes down purely to the paediatrics and neonate side of it, really. Yeah.
Do you have a big kind of home midwifery or doula led, or even Indigenous support services for labours at home that you may have to take care of everything?
Yeah, so it has been an issue over time, and I think a lot of rural parts, that's a very popular thing, is to have this sort of home midwife service. So we try and avoid any home births here in the Kimberley. But yes, there is a very strong sort of Indigenous women's clinic at the local AMS that try to do all the management and do a great job. And which is the Aboriginal Medical Service. So that's all done through there, and community midwives that go out and visit. But fortunately, we haven't had too many actual home births over the years, so that's good. A few we've had in the ambulance bay. But, yeah.
Okay, good. That's interesting to think. We just don't see too many. I mean, the problem's obviously rare. It's when they go wrong, it becomes disastrous, and that's when you really have to step into gear. But often in the big city hospitals, I haven't seen too many of that. So that's been
it's one thing I would say is that a sick mum and a sick baby, if you've got a scenario where you've got a woman that's unwell and then the baby comes out unwell, that very quickly, even in a reasonably big place like Broome, that very quickly uses up your whole team, and that can go on for hours and hours. And it's amazing how much resource that burns. And you as the GPA, you sort of have to think about the bigger picture as well as what else is going on in the hospital. Like, that's not the only patient. There's heart attacks in the ED, and there's trauma coming in as well. So if that's something that you've thought about in your pessimistic planning sort of mode, like how much resources it's going to use, that could be another reason to sort of think maybe we were better off going somewhere else, because it can be incredibly taxing on the whole hospital when you have something like that. Yeah,
it's such a good point. I mean, I think about it all the time in my kind of tertiary hospital context, where, am I going to start an elective-ish Caesar when I've got 20 labour women plus one that's got preeclampsia, and another one, maybe HDU is full or something like that. You don't want to start a new case. And if you're in this new hospital, to be able to think about what else is going on in the hospital, or have they called in a trauma, then, to stop doing everything and just wait for the disaster,
Yep. Yeah. That never works that way. Women always give birth. It's exactly the wrong moment, unfortunately. Yeah.
Yeah, 3 a.m. in the morning.
Yeah, 3 a.m. Yeah.
Actually, what are your thoughts? So, we've probably covered most of these kind of factors of patient, pathology, personnel, place. In terms of the patient, what is the sense that if someone is a likely difficult spinal and likely to go to a general anesthetic, is that something that's kind of seen as high risk and we wouldn't want to do it? Or?
Yeah, it's really tricky. And obviously, if we know the obstetric history and you can look back and see how your mate struggled 2 years ago, that's always the best thing. Yeah. It's something that we discuss a little bit, and no offense to tertiary hospitals, but like our team up here, we have, like, everyone's a 15 to 20 year veteran of obstetric anaesthetics here. And you think, are we actually worse at putting in these spinals than if they go down to the tertiary and the second year registrar does it? Like, it's sort of like, like, for at least they've got the old consultant there that will help them. And I think it's certainly a consideration, and like, we all like to have a look at the back and have a feel, but it can be really tricky to know exactly how difficult until you've actually started trying to explore that spine. And I've got to confess, I'm an ultrasound tragic, and so I think ultrasound has changed that decision making in my head a little bit, in that I'm reasonably confident now that if I can't feel anything, I'll actually, in the clinic, get the ultrasound out and have a look, and if I'm happy that I've got good views and I think, I can get this in, then I'm quite happy to proceed with that sort of case, because I think ultrasound has changed things a bit. And at the end of the day, if it's an elective cesarean and I get my ultrasound and I still can't do it, I haven't actually lost too much. Like, I can always still, call a friend or put that person on the plane that next day and get them to the city for their elective procedure. But I think ultrasound has changed that a bit. I think that the number of women who, I think I'm not going to be able to get this in is very small now. So there'll still be, I'm sure it'll happen one day. It hasn't happened for a few years, but I tend to be, if I get asked to come in as the second because someone's struggling to get a spinal in, I just go for ultrasound straight away now. Yeah,
it's almost, I find that it's nice to be the second person, because I haven't lost their confidence by having the 5 attempts previously. Yep. And also, it's, I guess, something, so people who are just training, it's just no shame in missing the first spinal, because it's through, say my colleague had some failures, I now learn from their experience of failure to make. I'm standing on their shoulders in a way, and I would have probably done the same method that they did. And maybe if they look really difficult with scoliosis or whatever, I may have put the ultrasound on, but often I just have a crack anyway. Because more often than not, even obesity and scoliosis, you're fine. Like,
Good. Yeah. It's the same with IV access. I know that this is something that you've made videos about, but I have a thing I call Parker's paradox, whereas if you get called and someone's already got like 7 sticky dots on their arm, all the bad veins are used. So the one that's left has to be the right one. So the space that hasn't been tried yet, that's where you want to go.
One vein. Parker's paradox. Right?
Yeah, the blood has to get back to the heart somehow.
That's right. There's definitely a vein. Yeah, it depends how deep it is, and
ultrasound once again.
So how about the GA? I know when I was training, based on data from the UK, I believe it was, which was a lot of less trained anesthetic registrars by themselves managing obstetric airways, which is in a rush, bad positioning, with all the pregnancy issues of low FRC and you know, badness. And so we had really high rates of, you know, failed airways in pregnant ladies. This was old data. You know, looking at new data is actually not too bad. And that's my feeling that actually this is not a bad area. So GA for cesareans, is that if you know you're going to do a GA in this context, are there certain hospitals that would say, no, look, we don't do GA Caesars?
It's really interesting, and this comes up. We have a chat group that's Australia-wide, which you're part of now, and this comes up pretty much every year when the new registrars graduate and go out into the bush, and they get told by the hospital, no, you can't do that here. And like, I'm old, and I trained in that era when everyone was like completely paranoid about doing GA because you just think everything's going to go horribly wrong, and it, you know, it still can go wrong. But as you said, proper preparation is the most important thing. And if you, with the stuff we have now, with the, you know, nice ramping pillows and the apneic oxygenation and everything else, it's actually, you know, I'd much rather tube a obstetric patient than most of the traumas I do, or like the guy that's got really severe pneumonia who we tube without sort of thinking too hard about it. So I think we've overblown that risk a little bit. But having said that, this is an elective procedure, and this is one where the patient, if they're electing to have a GA for whatever reason, actually a really important thing I would say, and I'll come back to the GA thing in a minute, but most of the women over the years that I've had come into the clinic saying that they refuse to have a spinal or an epidural, they only want to have a GA, it's pretty much about, I'd say most of them, it's been about misperceptions, and they've had a horrible experience. Usually they've had an epidural in, and then someone's topped it up and it hasn't really worked very well, and they've had a horrible traumatic birth. And if you just spend 10 or 15 minutes with them and go through that experience, often you can remove that fear, and they don't really want a GA anymore. They're quite happy to, because there's a very big difference between that and having a simple elective spinal in a, you know, theatre with the music playing and everything else. So I think, and to take it even further, if I have a woman who does have a horrible epidural top-up experience, I make a point of going back and talking to them the next day or the day after that and doing some counselling and explaining that, you know, in 3 years' time when you're having another baby, you know, that's something that you need to think that we will do it very differently.
Actually, really good. You're managing the problem in the future.
Because what would future me not like to be battling? So I think that's something that we as GP anaesthetists should be doing really well, and so you can avoid that scenario. But anyway, go back to doing the GA. I think it's something that we can do, and we probably should be doing. At the end of the day, women get to make these choices about what they want, and I think our risk is overblown in our head. So I think, yes, doing a GA in a small hospital is fine. But once again, you need to have your team. If the paediatricians aren't on board, if they feel uncomfortable with it, then it's a no-go. The obstetricians are always happy with that sort of thing because it makes their job easier. And I guess
the bleed risk.
The bleed risk is,
as long as you remember to turn the nitrous on or start TIVA, more environmentally friendly, your uterus won't be lax, and it will actually contract properly. So I think that's something that you really need to sort of have a team-based approach. But I'm much more relaxed about that nowadays. And I guess the other thing to say is that risk of GA doesn't really change which hospital they're in, because it's if you're a conservative GP anaesthetist and you do all your planning, you're probably just as likely to get it right as anyone else, unless they've got a horrible leaking airway or they're telling you that they had to have an awake fibre optic for their gallbladder last time. Yeah, maybe not. So you take all these things and look at it all together. But I think we should be doing that where necessary. It is interesting, like the concept of, as soon as you change the context to, like, trauma, patient comes in, you give a GA without even thinking, because that's just what needs to happen. You're pushed to do that by a lot of, it's the right decision, tradition, the processes that happen, versus a well person not expected to have a bad outcome, and you've been told that GA is more risk, and you've got a baby to consider. It's such a spanner in the works of a normal decision-making tree, just because suddenly the context is very different. And I've just thought about that so often when people, in one context, they'll use suxmethonia, which is high anaphylaxis risk, like it's lollywater, ECT list. We just use sux like we don't care. But as soon as you have to decide on giving a bit of sux for a laryngospasm, you're like, or you're trying to choose sux for a short case versus putting an LMA in because of a slight aspiration risk. You suddenly get really focused on the fact that it sucks. And that's just a contextual thing. Right?
Yeah, it's interesting. We worry about risks that are sometimes 2 decimal places further over for elective stuff than we do for stuff that we just have no say in whatsoever, because it's just going to happen no matter what we do. So, I think it's something we all just sort of need to meditate on beforehand when we do these things. And obviously, we cowboys, we don't want to be cowboys, but I think in the modern era, with all the kit we've got and the drilling and the planning we do with CAICO situations and everything, I think we're actually pretty safe for doing these cases. Yep.
That's good. So I think we've covered quite a bit of detail about, and probably hopefully a framework for everyone to kind of consider as they're, if you're a training anaesthetist or GP anaesthetist, just to consider what it's like in the real context. And even though we've looked at the framework for obstetric referral, really this applies to so many other situations. You're thinking about patient pathology, place, personnel, and also the post-op location, what resources you have. So just as a framework, I think that still holds well. And I'd say I'd use this kind of on reflex every day that I'm considering cases, because you never know. You're not just going to get the regular case that comes in for a simple gynae op or a lap chole. It's always a bit different. And now that I'm working in Broome for a bit, I'm really thinking about that more than I've ever had to think, because I'm like, I'd normally just do this or I wouldn't do this. And what's the context now? It is tricky, but I don't think there are hard and fast answers. And the stuff that you can control, the stuff that you can't control. And then there's this grey bit in the middle. And I guess a lot of it is just about trying to make that grey bit as small as possible and trying to, and sitting with your team and nutting it out. Because I think over the years, sometimes just having a chat with one of your colleagues, the answer becomes very clear very quickly once you have a chat with one of your colleagues and they go, well, why would you do that? So just make sure that people are comfortable saying no to you. And telling you this is actually going to be dangerous.
Cool.
Yeah. Well, hey, thanks very much.
It's been a pleasure.
Yeah. As our first combined Broome Docs and ABC's Anaesthesia podcast, has been great. And I guess, if you enjoyed listening to this, please share with anyone who might be interested. And we'll see you next time for further information about anaesthetic related issues. See you then.
See ya.